Hello friends, today our case is 9-year-old female who was subjected to a bending force to the left little finger causing displaced fracture at the base of the proximal phalanx. And basic objective of this video is to guide orthopedic resident and junior surgeon for this straightforward procedure. Patient was prepped and draped under the digital ring block and hand secured on the hand table. Initial CM image show marked abducted position of the little finger. Now for reduction, we apply a longitudinal traction persistently for about a minute. Most of the deformity are corrected with this longitudinal traction alone. I placed a rolled gauze piece deep into the web space between ring and little finger. Here, gauze piece acts as a fulcrum, applying an adduction force to the little finger to snap back basal fracture back into alignment. We continue with mini adjustment until the anatomical reduction is achieved. Before pinning, check the rotational alignment by gently flexing the fingers into a fist. Ensure all the fingertips point towards the scaphoid tubercle of the wrist to rule out the malrotation. Our plan for K-wire construct is 2 1 mm K-wire in crossed fashion advancing proximal to distally and extra-articularly. For pinning, initially place the K-wire outside the skin and check the trajectory on the C-arm. Then advance the wire manually through the soft tissue until you feel the resistance of the bone and confirm the entry point on C-arm before starting to drill. Drill across the fracture site into the far cortex, checking oblique and lateral views to ensure intramedullary placement. Similarly for lateral K-wire, first check its direction in C-arm. Insert K-wire manually to bone resistance. Confirm its bone entry. Drill it in a cross fashion with regularly confirming its position in C-arm. Then bend and cut the K-wire. 1 mm K-wire can be easily bent by hand itself. As the procedure is being done under ring block, we can ask the patient to make a fist and extend the finger at the end of the procedure. This helps to confirm the perfect rotational alignment and no tendon catching or joint penetration by the hardware. Then we apply sterile dressing, immobilize the hand in ulnar gutter slab. We plan to maintain the immobilization for 1 month, followed by removal of both slab and K-wire, and active mobilization is started then after. This was our post-op X-ray. Thank you for watching and do remember to subscribe for similar content.